You are listening to the global network of podcasters dedicated to the pharmacy profession. Welcome to the Pharmacy Podcast Network.
The testimonials appearing in this podcast reflect individual experiences and individual results may vary. Cardinal Health does not claim, nor should the listener assume, that any individual experience recounted in this podcast is representative of what another consumer may experience.
Welcome to Nourishing Conversations and Enteral Nutrition, brought to you by Cardinal Health. Join us as we connect with clinical experts to explore a variety of topics related to nutrition support. I'm your host, registered dietitian nutritionist, and board-certified nutrition support clinician, Christina Rollins. Let's get to it. Hello, and thank you for listening to the Cardinal Health Medical Affairs Podcast, Nourishing Conversations and Enteral Nutrition. Joining me from the Children's Hospital of Orange County, or CHOC Children's, as it is commonly called, is registered dietitian nutritionist Catherine Bennett, here to talk with us about blenderized tube feeding. Catherine has over 20 years of experience working as a pediatric dietitian and has become a specialist in pediatric enteral support and blenderized tube feedings, also known as BTF, serving children of all ages through CHOC Children's Hospital Gastroenterology and Nutrition Program. She started CHOC Children's first blenderized diet program and support group and continues to advocate for BTFs to all who can benefit. Catherine is a published author and has spoken on the local and national level on BTF, encouraging further education and support of real food-based tube feeding and its benefits. In 2020, she published an invited review entitled Blenderized Tube Feeding, Health Outcomes and Review of Homemade and Commercially Prepared Products in Nutrition and Clinical Practice. And this article was recently referenced in Blenderized Tube Feedings, Practice Recommendations from the American Society for Parenteral and Enteral Nutrition. Catherine is currently the principal investigator on a CHOC Children's research project evaluating the impact of BTF on feeding intolerance and the gut microbiome in pediatric tube-fed patients. Catherine, thank you so much for joining us today on the Cardinal Health Medical Affairs Podcast.
Thank you so much for having me, Christina.
Well, Catherine, you've really created a niche for yourself in nutrition support and the quote-unquote world of BTF. Tell us more about your career path and what led you to this point.
Sure, I'm happy to share. I never would have imagined the place I'm in today when I started a little bit over 20 years ago. I've always practiced in the pediatric realm. I initially started in the NICU, followed by more general pediatrics, both inpatient and outpatient. And then the last 10, 11-ish years, I've been primarily in outpatient GI. And that had led me to meeting my first blenderized tube feeding patient about that same time. And she was an X24-week preemie who was fed through a gastrostomy tube and struggling with reflux and vomiting. And her GI physician, I think, wasn't sure what to do. They tried a lot of medications, and this mom really wanted to do a blenderized diet for her daughter. So we got the okay from her GI physician, and I said, well, if you'll let me, quote unquote, experiment and work together to work on this blended diet. I told her she would be my first patient, and she was gung-ho. And so we worked together, and really, at that point, never looked back, and her daughter did great. And I think the physician was impressed, and it kind of started this trend at the time of using blenderized tube feedings for our patients who weren't tolerating their traditional formula.
Well, the idea of blending food and administering through an enteral access device is certainly not new. Pre-1970, before commercially prepared tube feeding formulas were readily available, blending solid foods and liquids were necessary to feed patients who had a functional gut but were unable to safely consume adequate amounts of food and fluid by mouth. Recently, though, we've seen this sort of resurgence of BTF. And in fact, your 2020 article, you referenced surveys that found as many as 89% of patients chose BTF to meet some or all of their feeding needs. In your opinion, what's driving this BTF utilization?
So, both the literature as well as what we're seeing in clinical practice really supports this increased use of BTF due to a couple of reasons. I think one of the top reasons is the patient or caregiver preference. They really want to feed or eat what others in the household are eating. Caregivers would love to have more control over what they're feeding their loved one, their child. I do hear concerns about the processed nature of standard commercial formulas, and so they want to give a less processed diet, and even one that closely matches their own food cultures. I think a second, reason why we're seeing increased use of BTF is we're seeing a lot more improvements in feeding tolerance, less reflux, vomiting, improved stooling patterns, even some increased interest in kids wanting to eat by mouth. Some of my patients have even reported improved energy level, skin color, even improving in their therapies. And so I think these two reasons are really driving the interest and use of blenderized tube feeding.
So let's talk tolerance. Have your patients experienced improved gastrointestinal tolerance with BTF as compared to commercially prepared products?
So overall, yes. I have seen similar improved tolerance with either doing a home blenderized tube feeding or a commercially prepared blenderized tube feeding product. So I don't think we have any head-to-head studies. It would be interesting to see if we can tease out if we can see a difference in benefits between the two. I will often recommend that my patients they're doing a home prepared blenderized tube feeding, that they have some sort of formula for quote unquote backup, meaning if they can't blend one day, or maybe they choose not to blend depending on their schedule. I have families that will blend during the week and take off on the weekend. And so we try to find a formula that they're comfortable with. And many times that ends up being a commercially prepared blenderized tube feeding formula, or a formula with real food ingredients to help maintain that tolerance. And usually that is quite successful.
So it doesn't have to be an all or none situation, right? We can work with our patients to help them find a regimen that works for them, which may include both BTF and commercially prepared products.
Yeah, absolutely does not have to be, one or the other. I do share with my family, sometimes they feel guilty about not, being able to sustain a home blend because it does take some time, right? And so I usually tell them, think where you want to put your energy in caring for your loved one, your child. What do you want to focus on? And if they want the benefits of real food, but struggle with the time or the schedule or the ability, I ask them to release some of that guilt, and we can use a commercially made product and see similar results.
How is the gut microbiome impacted by BTF?
That's a great question. So we, as you mentioned earlier, we are finishing up our study on the gut microbiome in patients who are tube fed with a blended diet and on a commercial formula. And as we both know, the gut microbiome has really been a hot topic for quite some time now, and it deserves to be so. We know baseline that our gut microbiome is impacted by what we eat. And so generally speaking, the more diverse our gut microbiome is, the healthier or the better. And so some research showing that, diets that are low in fibers, high in fat, high in sugar, don't have a lot of variety, and also high in processed foods can really negatively impact our gut microbiome or contribute to less diversity. Alternatively, a diet higher in fiber, fermented foods, greater variety of more whole foods can positively impact the gut microbiome or create a greater diversity of microbes. Another cool thing about fiber is that getting adequate fiber in the diet really helps maintain the integrity of the intestinal lining and can reduce the risk of a pathogenic infection. So another reason, or many reasons why a blended diet made with real foods, or even a commercial product with a variety of ingredients and fibers, can positively impact the gut microbiome.
What are some other ways that BTF adds value to a patient's nutrition support regimen?
I think blenderized tube feeding really makes tube feeding quote unquote more normal, right? There's so much out of a caregiver's or a patient's control when they have long-term medical issues. And so, many of us in this space of blenderized tube feeding and working with patients who are tube fed really want to try to make tube feeding fit into their lives as a way to eat and not the other way around. And so I think using blenderized tube feeding gives a choice of what to eat back to the patient or caregiver.
In your experience, who typically presents the idea of BTF? Is it the patient and the family, or is it the clinician?
I would say initially it was mostly the patient and the family. And so I think that's what's started and driven this movement of blenderized tube feeding. It definitely, in my opinion, wasn't us as clinicians, right? We were taught that nothing goes through a tube except medications, water, and standard formula. And so I think initially, in my experience, it was the patients and families coming in. But now, at least at my hospital, our team of clinicians are presenting it to their patients as an option, especially in the case of tube feeding intolerance. And so right now, although it wasn't always the case, I see kind of equal interest in home blenderized tube feeding and the commercial blenderized tube feeding products from both the patient family as well as our clinicians recommending it. When patients meet with me for the first time, we kind of review all the options and work together to figure out what the best plan would be for them. Sometimes the providers or clinicians refer them to me for a blenderized tube feeding. And sometimes the families are ready. They know exactly what they want to do, but sometimes they don't even know what it entails. And so we might start off with keeping their standard commercial formula on board and just adding in a few snacks versus the family or patient who's ready to transition off commercial standard formula onto a home blended diet. It's kind of, really dependent on what works best for that patient and their family.
Are BTFs used solely in the home setting, or are patients also able to initiate or continue their BTF regimen when they're hospitalized?
It depends on the individual hospital. In my hospital, patients who are already on a home prepared blenderized tube feeding are allowed to bring in their blends. And if they can't, then they can choose a commercial blenderized tube feeding option from our formulary list. Some institutions will even prepare a blenderized tube feeding for their hospitalized patients. However, our hospital does not do that at this time.
Thinking about enteral access devices, is a gastrostomy tube required?
There's this question has been I think asked a lot, and I would say most of my patients on a blenderized tube feeding of some sort do have a gastrostomy tube. We have a couple of patients using the J port of their jejunostomy tube for small amounts of commercial and or home blenderized tube feeding, in addition to a formula, somewhat of a hybrid regimen, and they're doing well. But the plan with these particular patients is to slowly wean from their J port to the G port. There is debate about using a blenderized tube feeding through a J tube into the intestine, but it doesn't seem that any consensus has been made at this time. I would be open to doing it, but I'd be very judicious about the food choices and, of course, closely monitor them.
So I think that really goes back to having a clinician on board who is well versed in enteral nutrition options and can help create that patient focused or patient specific care plan.
Absolutely. I think, at least in my experience, when I have patients come to me already have started a blenderized tube feeding, it's probably about a 50-50 split. About 50 of them are struggling to get in the nutrition, get the consistency right, and might be lacking in several nutrients, versus about 50% are doing fairly well. So I think it is crucial that they meet with a registered dietitian nutritionist who's experienced in enteral and hopefully blenderized tube feeding so that we can make it a safer and overall better experience.
I'd like to take a few moments and get your thoughts on common administration methods. So, syringe, gravity, and pump. What is the prevalence of each method, and what are some considerations that our listeners should keep in mind when caring for patients who are incorporating BTF into their nutrition support regimen?
So I present a whole list of options for my families, and we kind of go through them all, the pros and cons. Getting into this practice of blenderized tube feedings, I thought, oh, it'd be great. All of my patients that are pump dependent because they can't tolerate, bolus feedings are going to want to get off their pump and, they'll be happy to. I will say at this point, I probably have at least 50% of my patients doing some sort of blenderized tube feeding, still using their pumps. And if a patient or a family would like to stay using their pumps, then, we really talk about blend ingredients and consistencies so that we maybe prevent any pump issues to begin with. Sometimes families are really comfortable with syringe bolus feedings. And so sometimes families will move away from the pump to syringe, or maybe they started on syringe bolus feedings anyway. I would say these are probably more ideal than the pump for all consistencies. But in my opinion, the syringes that my families get are of poor quality. Over a short amount of time, they get really hard to push. That plunger, the rubber part on the plunger gets stiff, and so it can be really require a lot of strength to push in the plunger and get the food out of the syringe. Some of my families need to do multiple syringes for large volume feedings. And so if it's really challenging to push that plunger down, it could take a lot of effort and cause a lot of maybe hand issues potentially for doing, multiple syringe feedings multiple times per day. But again, it is an option. And then lastly, we have a gravity, which I don't think works very well for a blenderized tube feeding. Usually they're too thick. It doesn't work unless we have it pretty thin. And if we do get it thinned out, we might lose some of the nutrition, the density or the caloric density of the blend. And so above all, I ask my patients a lot of questions about which of these methods would work best for their life. What do they envision, right? Coming in to see me, what did they envision their blenderized tube feeding life to look like? And again, I do provide education on the pros and cons for each of these and do spend some time troubleshooting if one method doesn't work as well and we need to try another.
Walk us through a typical day for a patient receiving BTF at home.
Well, it really varies for each patient and each family. My goal with all of my patients that eat through a tube is to try to keep the regimen as simple and easy as possible, one that works for their life, not necessarily mine. So, meaning if it's easier for them and more challenging for me to calculate or whatnot, we'll go for it. Some families will blend every day, some every couple of weeks, and then some I have do these really large batches. And so they're blending once a month. And of course, those blends get stored in a freezer. Some will give their blenderized tube feedings every day, others only on weekends. I've had families, if they're on a pump drip of formula overnight, standard formula, we'll continue that, but we'll do blenderized tube feedings during the day. I usually say, this, whatever we decide today or this month doesn't mean we have to stick with that for months or years. And so I do see as, my patients grow and get older and their needs change, that we are varying the regimen. I don't think I can say there is one typical day, as every patient has their own unique relationship with blends and really does what works best for them.
You've mentioned a couple of times and alluded to viscosity. How common are tube occlusions, specifically when using BTF?
My knowledge, there haven't been head-to-head studies on tube clogging with blenderized tube feeding versus formulas. But in my experience, it can happen. In my practice, I don't see it happening too often, so much so that it's a barrier, as I rarely hear about it. And I do ask, especially in the initial follow-up visits, once, we've started a blenderized tube feeding regimen, I do ask. But it does, I will say it can happen. It does happen. It can also happen, with medication. And so we do not start a blenderized tube feeding or homemade blenderized tube feeding when someone initially gets their gastrostomy tube. We will wait until they get their low profile device to start, because of course, if that initial gastrostomy tube that gets placed, if that gets clogged, then they have to go back in under anesthesia and get that replaced. And so that is one thing that we do, is wait until we have a low profile device, because if that gets clogged and we can't get rid of the clog, we can just pull out that device and replace it easily at home. But I do try to do a lot of education up front, because my goal is to prevent the clogs before they happen. So we do talk a lot about food choices that thicken the blend, like rice, breads, avocado, banana, and then really, talking about what that final consistency is going to look like. Again, all with the goal of preventing clogs before they happen.
What are some other risks associated with BTF?
So overall, I look for a motivated, engaged caregiver or patient. And then I strive to have a good relationship with them as well. And so when we have this combination, I think the risks can be low. I also think education is the key, right? So meaning they're attending their follow-up visits with me. We're educating both our patients and their caregivers, but also ourselves as clinicians. So we're staying up to date with the research and development. I always tell my patients, that if they don't like what I'm recommending, to please be honest with me so that we can work together to meet both our goals. For example, if I present a meal plan or a recipe for a home prepared blenderized tube feeding, and they, don't tell me up front that they want to be vegan, and then they go home and start doing a vegan blend. And then I don't know, what risk to anticipate, for example, because I'm assuming that they're including, all the food groups. However, if a patient or caregiver becomes lost to follow-up, and it can happen, or if recommendations are not followed, this can happen, or if a patient starts on their own and doesn't get care from a dietitian, these can increase the risk of malnutrition and or nutrient deficiencies. So, and I talk about this with my patients, I'm here to help ensure nutritional adequacy so that, our patients can grow, thrive, or maintain a healthy weight and nutrition status. And so to help mitigate at least some nutrient deficiency risks, I often recommend a multivitamin and mineral supplement. And I'm currently working on a lab monitoring protocol for our tube-fed patients, both on home or commercial blends, but also even on standard formulas. Some of our tube-fed patients may be at a higher nutrition risk just due to their underlying condition, or maybe a medication use that's affecting the absorption of certain minerals or vitamins. So they might require more frequent monitoring, and supplementation is usually warranted.
Catherine, what are your top 3 talking points when educating patients on the pros and the cons of BTF?
It's hard to narrow them down to top 3, but yes, I do notice a trend in my education. So my initial visit with patients are about an hour, and it can take the full hour, right, to get in all this education and really figure out what works best for, these patients. In terms of pros, I would say improved feeding tolerance. And I think this can lead to a better quality of life. I had a mom tell me, this was years ago, that her physician told her, it's going to take a lot of work to blenderize this food, right? It's so much harder than opening up, a can of formula. And she said, I told him that, well, it's time that I'd rather put into making my son's food than cleaning up his vomit all the time, multiple times per day. So improved feeding tolerance, which I think leads to just a better quality of life for the patient themselves and their family. Another pro I would say is more control over their tube feeding, right? So there's many things that a chronically ill, or I guess a person with a long-term chronic medical condition doesn't have control over. And so I think giving them control over what they eat, albeit through a tube, they can choose the food, is another huge pro. And then I would probably categorize improved health benefits as my third pro, right? I'm really seeing not just improved feeding intolerance, but I think there's improved quality of life and improved health, meaning overall, I don't think we have any literature on long-term benefits of a real food tube feeding yet, but we're getting more real food in their diet. We're getting more fiber and more variety. And so all of this is good for our gut microbiome, which overall could improve health. In terms of cons, yes, more time. It'll take more time, at least initially, a lot more time. But then as we get good at it, right? Families tell me, oh, it takes me 10 minutes. And many of my families will have their recipe memorized and can just tell it to me off the top of my head. And like the experience I shared earlier, right? It just, where do they want to put their energy? What do they want to have their time focused on? And preparing food for their loved one is overall more positive, right? More positive way to spend time. A second con, if it is a con, but sometimes it can be, is just more healthcare visits for that patient. So medically complex patients, they have a whole team of providers to see. And so I do say, listen, I'm now on your medical team, but if we want to do this blenderized tube feeding, then, I would love to be a member of your team, and we got to keep checking in with each other. And that means you have to make a visit and have another appointment. So that could be, kind of stressful when they're already seeing a lot of people and just adding another medical professional to visit. But I do offer in-person and telehealth visits. And so I do try to work with the family to make it as easy as possible for them. I would say a third con would be more education. These education sessions or visits with me, again, it isn't as easy as opening a can or a carton of formula. And the education required to do a blend, while not anything exotic, it's just more, right? Especially in terms of troubleshooting and ensuring adequate nutrition. And so my patients might not have good health literacy. They might not have the tools or the resources to do, a home blend as you'd like it to be done. So I really think there is just, maybe not necessarily a con, but just we do have to have thorough and ongoing education to ensure good outcomes on a blenderized tube feeding diet.
As you're following your patients and working with their ongoing care plan, what are some markers of success that you look for when you're creating those nutrition reassessments?
So thinking about, let's say I've met with a patient, we started a blend, and then I typically do a 1-month follow-up after that. I tell them that I need to have that 1-month follow-up regardless if you're doing well, because I want to see. I tell them the whites of their eyes. I want to look for how stressed are they, how worried, how well is it going? And so I do that, families get busy and things fall to the wayside. And so having that 1-month check-in, I think, is really helpful. And I like to see them face to face and really, tell me for real, how is it going? And so other things that I look for besides just overall stress level are the patients meeting weight gain or growth goals, right? If we maintained that growth velocity and weight gain in that last month. Also, I'm really looking for improved tolerance or even resolved feeding intolerance. And so, many times my families come back to me in a month and say, vomiting, stooling issues have completely resolved or significantly improved. And so when I hear that, I'm like, yes, we've had such an impact on using a blenderized tube feeding on their feeding intolerance for this patient. I will ask them about how their schedule's going, right? Because now that they are off formula, right, and they're spending more time preparing food potentially, but maybe this means they have more time off the pump. Maybe we've consolidated and now we've got more hours free during the day. As mentioned earlier, maybe they have less time cleaning up vomiting or stooling issues. And so I am really looking for these, what I feel are improvements in quality of life. And then one final thing that I do look for and ask a lot of questions about is, how are they preparing and giving the blenderized tube feeding? Have they changed the recipe because of food preference? Have they changed it because it was too thick and giving them issues when delivering through a pump? And so a marker of success would be that they're not having any problems with delivering or preparing a blenderized tube feeding diet. And if they are, then we need to troubleshoot and figure out, what are those issues and how we can improve them.
Well, we just have a couple of minutes left in this episode. So I'd like to ask, what advice would you give our listeners when caring for patients receiving or who may benefit from switching to a BTF?
I would encourage listeners, to be open and listen to your patients. It can be scary, right, to not necessarily know exactly everything your patient is getting. And it might be more work on your end to calculate a blended meal plan, a recipe, to work on the regimen and monitor than, looking at, the formula, a commercial formula carton label. But I think it can greatly improve your patient's tube feeding experience and quality of life. I feel like my worlds have collided practicing in this space. The reason I went into this profession was to use food as medicine. And this, combined with my love of nutrition support, has really allowed me to help my patients in ways that I never imagined. So be open and listen and surround yourself or gather resources that will support you. I feel very well supported at my institution, but I've also done my own research and sought out information to help me be a better clinician in the blenderized tube feeding space. And, it is truly rewarding, albeit challenging and frustrating at times. And I really hope that others can find it so as well.
Well, with that, we will go ahead and conclude today's podcast. Catherine, thank you so much for taking time out of your busy schedule to chat with us today, and really for all that you're doing to advance care using blenderized tube feeding.
Well, thank you, Christina. It was such a pleasure to be here with you today.
And listeners, thank you for joining today's episode of Nourishing Conversations in Enteral Nutrition. Be sure to like and follow us wherever you listen to your favorite podcast. Until next time, I'm Christina Rollins. Thanks for listening.